This is Roy Stroud with the Department of Neurology at Johns Hopkins, and I'm back to talk with you about part 2 of the series on how to think like a neurologist. As you will recall in part 1, we talked about the initial steps of evaluating a patient with neurologic illness, and specifically one method or recipe for localizing a patient's signs and symptoms to an area of the neuroaxis. In part 2, we'll use this understanding of localization, to develop a focused differential diagnosis and talk through the thought process behind some of our diagnostic testing. So why talk about how to develop a differential diagnosis? Why not just list all the neurologic diseases and work our way through how they present? Well, the simple answer for me is that I just can't remember all those diseases. I struggle to come up with 7 or 8 diagnoses, much less rifle through the hundreds of conditions that can cause neurologic disease when I'm seeing a patient. But I think most importantly, this comes down to the fact that if we can localize where the problem's coming from, if we can figure out where in the nervous system it's coming from, there only tends to be about 6 or 7 common diseases that affect that level. There's 7 or so common muscle diseases, there's 3 junctional disorders that you should know, a few more nerve conditions, and about 7 or so spinal cord disorders, and so on and so forth, up the brainstem, subcortex, and brain. And so the better job we do localizing, the more focused our differential will be, and the easier our workup is. So, what's the recipe for developing a neurologic differential diagnosis? How do we do this? Well, the first step is building a framework. How to think about neurologic disease, and there's really no one right answer for how to do this, and we all really have to come up with something that's best for us. But here's what I find has worked well. So I think back to the types of pathologic processes that affect the body, right? What are they? There's inflammation, when the body's immune system reacts against itself, or autoimmunity. There's infection. There's neoplasm or paraneoplastic disorder being when the body's immune system reacts to a cancer, and in doing so reacts to some other normal part of the body. There's toxic and metabolic conditions. There's inherited conditions, and then there's some other things like vascular disorders, degenerative things, and so on and so forth. And then recall that each of these types of processes tends to affect the neuroaxis differently. In other words, this gets back to that issue, that concept of tropism, or affinity of certain conditions for specific areas of the neuroaxis. So think back to acetylcholine receptor antibodies. They will never cause an encephalopathy, a brain problem, right? Because the neuromuscular junction is where those antibodies bind. There's a tropism for acetylcholine receptor antibodies for the antigens on the neuromuscular junction. And so when the body's immune system decides to go haywire and produces acetylcholine receptor antibodies, they don't act on the brain. They act on the postsynaptic membrane of the neuromuscular junction, and the patient develops junctional weakness. And the same thing goes for inflammation in the brain, the brainstem, the spinal cord, the nerve, and the muscle. That inflammatory response has an affinity for a specific area of the neuroaxis based on how it manifests and what receptors are present there. So each type of disease process, inflammation, infection, neoplasm, toxic metabolic problem, inherited problem, and the others will affect different levels of the neuroaxis differently. So again, this underscores the importance of localization. If we can figure out where the problem is, then we don't have to go through all the potential diseases that could be causing neurologic problems everywhere. We just have to figure out whether this problem is inflammatory, or whether it's infectious, or toxic, or metabolic, or inherited, or whatever. Because by doing that, we've narrowed things down from a large differential to a focused differential, and maybe a single leading diagnostic possibility. So let's walk through that. Let's go through building this framework of neurologic disease and start to build a structure for thinking through differential diagnosis in neurology. And we're not going to go through every single diagnosis specifically, but we will begin to develop the tools necessary to do so. So let's start again at the muscle. And let's think through the inflammatory, infectious, neoplastic, toxic metabolic, and inherited disorders that affect the muscle. And let's go back to that 34-year-old female, that same patient from session 1, from part 1. She presented with 3 months of progressive proximal weakness, difficulty getting up out of chairs, walking upstairs, reaching up to the top cabinets. She had normal reflexes, normal sensation, no bulbar symptoms, and we localized her problem where? To the muscle. And now we need to figure out if this muscle disease is going to be inflammatory, infectious, neoplastic, toxic, metabolic, inherited, or something else. How do we figure out if it's inflammatory? Let's start there. Is there something we can test, something we can do to determine if there's inflammation in the body? So one thing would be ESR-CRP, right? That tells us about inflammation in the body, but it's not really specific to the muscle. So there could be inflammation in the body that's actually not in the muscle, and that wouldn't help us. Is there something that's more specific for inflammation in the muscle? A CK. Excellent. So a CK is specific to the muscle, and the CK, after all, is one of the most abundant enzymes in the muscle. And so when there's inflammation or cell turnover and muscle is damaged, then CK is released. And so the first thing we do for this 34-year-old female is we check a CK, and we find that it's 4,000. It's elevated. So we know that inflammation is causing this patient's muscle disease, and now we need to figure out what types of inflammatory muscle disease there are. So what do we call inflammation in the muscle? What's the name that we give to that condition, particularly in a middle-aged female? Polymyositis, great. So polymyositis is an inflammatory attack, an inflammatory reaction on the muscle, common in middle-aged women, and presents with typical muscle pattern disease. And what if that same patient comes in with a rash? What do we call that? Dermatomyositis. Yeah, dermatomyositis, similar to poly, but with the rash. And then there's one last common inflammatory muscle disease. And this is a little bit different. The distribution is different. It's very characteristic. It causes proximal lower extremity weakness, difficulty getting up out of chairs, walking upstairs, and distal upper extremity weakness. So patients come in with difficulty opening up a bottle or using a pin or utensils or pliers or a screwdriver or those sorts of things. And this is actually more common in middle-aged men. Anybody know what this is called? Inclusion body myositis, right. That's the third characteristic inflammatory muscle disease. So polymyositis, dermatomyositis if there's a rash, and if there's distal upper extremity weakness, inclusion body myositis. Great. So by simply localizing this patient's problem to the muscle and checking a CK to prove that there's inflammation, we've narrowed the diagnostic possibilities down to about three things: poly, dermatomyositis, and inclusion body myositis. Great. So what about infections? What types of infections affect the muscle? What are the infectious muscle diseases? Yeah, so you can have a bacterial muscle infection, a pyomyositis. You can have a viral myositis. Fungi can affect the muscle. Yeah, those are less common. The thing that I would think about is probably HIV myositis, HIV-associated myositis. And this can actually present either at the time of seroconversion, early in the course of the disease, or later in the course of the disease with more fulminant sort of end-stage disease, and it's a typical muscle presentation in the setting of someone who has known HIV or has risk factors for HIV, which can guide us in terms of our testing. Neoplastic muscle disorders, there's not very many. They're very uncommon, but there are some cancer-associated muscle diseases, cancer-associated myopathies. Yeah, but let's move on. So toxic metabolic muscle conditions. There are a lot of these. What are some common toxins or metabolic conditions that affect the muscle? Yeah, there's a whole list of drugs. A whole list of drugs that can cause muscle damage. Two things to think about: statins, steroids. Statin-associated myopathy and a steroid myopathy, those will be common drugs to think about in terms of potential agents that can cause muscle damage. What else? What other metabolic conditions? Thyroid disease, good. So thyroid disease can cause a metabolic myopathy, particularly hypothyroidism. Remember, the muscles are highly metabolically active. They require that tonic hormonal input for adequate maintenance of muscle strength and integrity. Yeah, so hypothyroidism can cause a myopathy. And then things like rhabdomyolysis, right? And that's really more of a wastebasket term, descriptive term for a toxic metabolic damage to the muscle. And there's a whole list of causes of rhabdo: exercise-induced rhabdo, traumatic, heat stroke, genetic rhabdo, like metabolic myopathies or malignant hyperthermia, right? There's a whole list of potential causes of rhabdo, but those are common things to think about in terms of toxic metabolic myopathies. Statins, steroids, thyroid disease, rhabdo. Good. And then what do we call inherited muscle diseases? What if that runs in the family? Yeah, muscular dystrophy. Muscular dystrophy is the broad category given to a muscle disease that runs in the family or is genetic, is inherited. And there are a bunch of different types: Duchenne's, Becker's, limb-girdle, there's a whole list. But if it runs in the family, if it looks to be inherited, we call it a muscular dystrophy. Good, so let's see. There's 1, 2, 3, 4, 5, 6, 7, 8 maybe common muscle diseases. And we didn't even need expensive EMGs, nerve conductions, imaging, biopsies, right? We needed a physical exam, localize the problem, a CK for inflammatory, a risk factor assessment for infectious, a TSH, a med list review for toxic metabolic, and a family history. And we've narrowed that potential diagnoses down to a small list with maybe a single leading diagnosis. And what we've really done is we've really started to build a good foundation for how to think through diseases of the nervous system. After we localize the problem, if we can walk through the ways that inflammation, infection, neoplasm, paraneoplastic disorders, toxins, and metabolic problems affect the level of the nervous system, we can start to narrow our potential diagnostic possibilities down to a small list. Good, so that's the muscle. So let's move on to the neuromuscular junction. And let's start with inflammation. What do we call inflammation at the level of the neuromuscular junction? Good, myasthenia gravis, exactly. So myasthenia gravis is the name that we give to inflammation that affects the neuromuscular junction. And there's some common types of myasthenia, common subtypes. There's a few esoteric subtypes. But the point is that this is what we give the name to an immune attack on the junction. And so if we can prove that it's an immune attack, that it's inflammation, then we've cinched our diagnosis. So how do we do that? Well, CK won't help, right? CK was specific to the muscle, not the junction. What else can we test for? We could look for an antibody, yeah. So it happens to be that with neuromuscular junction disorders, we know the most common causative antibody. It's the acetylcholine receptor antibody. We've already been talking about it. And so in the right clinical setting, a junctional presentation and a positive acetylcholine receptor antibody, this will strongly point towards an inflammatory process. And the name for that is going to be myasthenia gravis. Good. So inflammation of the neuromuscular junction, myasthenia gravis, and the most common is going to be the acetylcholine receptor positive, seropositive myasthenia. How about infections? What happens when an infection has an affinity for the neuromuscular junction? What do we call that? Yeah, botulism. Botulism has a tropism for the neuromuscular junction because botulism produces this potent neurotoxin that's composed of both a heavy chain and a light chain. The heavy chain binds the receptor on the presynaptic terminus of the neuromuscular junction. This really facilitates the affinity, the tropism, for a junctional disorder. The heavy chain provides entry of this toxin into the nerve terminus, and the light chain then disrupts acetylcholine vesicle transmission, leading to symptomatic disease. So botulism is the name that we give to infections, or to this type of infection at the neuromuscular junction. Botulism, good. What about neoplastic, paraneoplastic conditions? What paraneoplastic disorder has an affinity for the neuromuscular junction? Lambert-Eaton syndrome. Good. Lambert-Eaton myasthenic syndrome is the name of the syndrome that is common in patients who have a paraneoplastic disorder against the neuromuscular junction, right? And what is this? This is a patient with small cell, most commonly or rarely non-Hodgkin's lymphoma or some other type of lymphoma, and the cancer produces an antigen that's recognized by the immune system. The immune system develops an antibody. That antibody reacts against the cancer, and that's good. But in so doing, the immune system also reacts against any other voltage-gated calcium channels, because that's what the antibody recognizes. And where are voltage-gated calcium channels? You got it, the presynaptic terminus of the neuromuscular junction, right? These channels, these voltage-gated calcium channels, facilitate calcium influx in the presynaptic terminus, and that facilitates binding of the vesicles to the presynaptic membrane and release of acetylcholine. So antibodies to the voltage-gated calcium channel disrupt this process and lead to a junctional syndrome. Lambert-Eaton myasthenic syndrome, good. So these are really the three neuromuscular junction disorders. There's myasthenia, myasthenia, myasthenia. And of course, right, well, remember botulism and Lambert-Eaton syndrome, but myasthenia is exceedingly more common than botulism and Lambert-Eaton syndrome. So myasthenia, botulism, Lambert-Eaton syndrome are the three common neuromuscular junction disorders that we're going to try to narrow down in those patients who have a junctional presentation. Now, in truth, there are some toxic metabolic disorders. Organophosphate poisoning probably would be the prototypical toxin that can result in a junctional process. There's a bunch of congenital myasthenia or myasthenic syndromes. There's neonatal myasthenia. So there are some inherited conditions, but those are exceedingly rare. And I think the things to remember are myasthenia, botulism, Lambert-Eaton syndrome. Good. So that's the muscle. That's the neuromuscular junction. What about the nerve? Let's talk about disease at the level of the nerve. What happens when the immune system reacts against the nerve? What do we call this? Okay, so I guess neuritis is technically a right answer, but let's be more descriptive than neuritis. So when the immune system causes a problem, it affects the entire body, right? And the immune system lives in the bloodstream, so when the immune system reacts against all of the body, it's actually reacting against all of the blood vessels all over the body, and thus against all of the nerves all over the body. And what do we call that? What type of neuropathy is a descriptor of nerves or nerve dysfunction all over the body? A polyneuropathy. Good. So we call this a polyneuropathy. And when the immune system is causing this polyneuropathy, when the immune system burrows through the vessels, the nervorum, all over the body and all over the nerves, so what does it encounter first? The myelin. Good, so we call that demyelinating. So we call inflammatory nerve diseases, polyneuropathies, we call them demyelinating. And if it's the immune system, we call immune diseases inflammatory. So good, so inflammation of the nerve is an inflammatory demyelinating polyneuropathy. And that's what we call it. We call it acute inflammatory demyelinating polyneuropathy or chronic inflammatory demyelinating polyneuropathy, AIDP or CIDP. Right, so I never said neurologists were smart, right? In fact, we're probably the opposite of that. And we call things like we see them. So if there's inflammation in the nerve, we simply call it AIDP, also called Guillain-Barré syndrome, if it happens in less than 8 weeks, and typically something that naters around 2 to 4 weeks into symptom onset. Or we call it CIDP, chronic inflammatory demyelinating polyneuropathy, if symptoms continue to progress after 8 weeks. So this is interesting, right? That means the onus is on us. If we can prove that a patient who presents with a nerve disorder has an inflammatory nerve disorder, all we have to know is whether the symptoms began within 8 weeks or beyond 8 weeks, and we can give you the diagnosis, AIDP or Guillain-Barré or CIDP. Good. So how do we prove inflammation? How do we prove inflammation in the nerve? Is there a blood test or an antibody or some of the things that we talked about with muscle and neuromuscular junction disease? No, you're right, no. What else could we do? How about a lumbar puncture? Does a lumbar puncture tell us about inflammation in the nerve? Let's think about that. When we do a lumbar puncture, where is it done? It's done at L4-5, maybe L3-4, the lower lumbar area. And where's the spinal cord end? Spinal cord ends at L2. Good, so L4-5 is actually below the spinal cord. It's the area of the what? The cauda equina. And the cauda equina is a group of peripheral nerves that have exited outside the spinal cord but are still within the spinal canal. So an LP actually tells us about problems, pathology, disorders of the proximal peripheral nerves, and of the central nervous system, the brain and spinal cord. So an LP is actually a good way to assess peripheral nerve pathology. So can an LP tell us about inflammation? What's an inflammatory LP? What do we look for? Well, some of the things that we get on an LP, right? White blood cells, protein, glucose, culture, a lot of things, right? So what do those things tell us about inflammation? Well, white blood cells, they tell us about infection, right? Leukocytosis in the systemic and the serum is a sign of infection. So elevated white blood cells tells us about infection, less commonly malignancy. So that doesn't tell us about inflammation. But what about protein? What does elevated protein suggest? Right, so protein is the most abundant entity within the cell. And so when there's cell turnover or cell death or inflammation, there's an elevation or release of protein. So good, so an inflammatory condition, an inflammatory nerve condition, will result in elevated protein and normal white blood cells. And what is that? What's the step one buzzword for normal white blood cells and elevated protein in a lumbar puncture? Yeah, that's albuminocytologic dissociation. Albumin or protein, cytologic or cells, dissociation. That's normal white blood cells and elevated protein. That's an inflammatory LP. And again, this isn't specific for Guillain-Barré, though it will tell us about inflammation in the nerve. It is specific for inflammation. So when we're looking for any inflammatory disorder in the peripheral nerve, the spinal cord, the brainstem or brain, we can use an LP to help define that. Great, so in the nerve, if a patient presents with a problem that we localize to the peripheral nerve, and we do an LP that shows elevated protein in normal cells, that's going to be inflammatory. If the presentation was within 4 to 8 weeks and does not persist beyond that, we call that AIDP, Guillain-Barré. If the symptoms progress for beyond 8 weeks, we call that CIDP, inflammatory nerve condition. Good. What about infections? What are some of the infections that affect the nerve? Yeah, actually the most common cause of neuropathy worldwide is an infection. It's leprosy. And then there are a bunch of other things, HSV, sensory nerve dysfunction, nerve problem, HIV, CMV, Lyme. There's also a bunch of other infectious nerve disorders, infectious neuropathies. But probably leprosy and HIV are the ones to think about. Infections of the nerve. We can also use the LP there, right? Elevated white blood cells and culture or viral PCRs. That can also help us in terms of evaluating an infectious cause of neuropathy. Good. What about neoplasms, paraneoplastic disorders? What are some of the things that cause nerve dysfunction that are cancer or cancer associated? Well, we don't have a ton of time to talk about these, but there is a condition, a group of conditions that affect the nerve called paraproteinemias. You remember these? Yep, things like multiple myeloma, monoclonal gammopathy of undetermined significance, right? These are a group of immune disorders that can result in neuropathy. Remember, these are disorders of immunoglobulins. Immunoglobulins are made up of heavy chains and light chains. To look for those heavy chains, what do? We look in the serum, and we can look on a serum protein electrophoresis or a serum protein immunofixation, and we're looking for the M spike, the elevation in a monoclonal heavy chain immunoglobulin population, right? We're looking for the M spike. We can also look in the urine, right? We can look in the urine for light chains, and we call light chain deposition in the urine Bence-Jones proteins. So we can look for an M spike or Bence-Jones proteins, and these are signs that there is increased paraprotein, increased immunoglobulin turnover. These conditions are result from overproduction in these paraproteins, and these proteins lodge in small vascular beds. Small vascular beds like the kidneys, small vascular beds like the nervo nervorum that we talked about. The nervo nervorum is the small capillary bed that coats all of the nerves. And so when you have disorders of increased protein and paraprotein synthesis, this can cause gumming up of the nervo nervorum. This can cause deposition within the small vascular bed around the nerves and a neuropathy. Good. It actually turns out that in men over the age of 50, paraproteinemias are actually a not uncommon cause of neuropathy, and that's definitely something that you will see or hear neurologists talking about in terms of causes of neuropathy in that population. Good. Okay, so let's move on. Toxic metabolic nerve disorders, right? There's a ton of these. Yeah, so there's a ton. Things like diabetes, most common neuropathy in the U.S. Alcoholism, very common in the United States. Thyroid disease, uremia or chronic renal disease, a bunch of drugs, vitamin deficiencies or toxicities, heavy metals, porphyria. There's a whole long list. But it's probably a list that can be pared down. So things like diabetes, alcoholism, thyroid disease, renal disease, and drugs are things that we can easily screen for and are common. So those are the things to think about. We can test for diabetes, we can screen on a history for alcoholism, we can test for thyroid and renal disease, and we can do a med list, a med review. So those 5 things are key things to think about when we're concerned for a toxic or a metabolic neuropathy. Good. Great. All right, and lastly, what do we call inherited conditions of the nerve? Call them all the same thing, a wastebasket term. What do we call that? Charcot-Marie-Tooth. Yep, so we call inherited nerve diseases Charcot-Marie-Tooth. And then that's the name that we give to those nerve conditions, nerve presentations that either run in families or which there is a clear common inherited link. And there's a bunch of different types of CMT, CMT1, 2, 3, X, so on and so forth. But if we can do a family history, if we can determine whether this runs in a patient's family or is long-standing, then we can put it in that CMT group or CMT basket. Good, so I've blabbered too much on these sorts of things, and I want to wrap it up. And so let's talk briefly about the spinal cord. But remember, the point is not that we review each of these diseases in detail. The point is that we start by building a structure, a framework, to think about these conditions, to figure out how to develop a good focused differential diagnosis. And if we can figure out where the problem is coming from, then we can use the test that we know how to run to figure out if that problem seems inflammatory, infectious, toxic, metabolic, neoplastic, perineoplastic, or inherited, and start to pare this list down into something that's a little bit more manageable. All right, so let's end with the spinal cord. What do we call inflammation of the spinal cord? Transverse myelitis. Good, we call it transverse myelitis. Again, a very descriptive term. Myelitis means inflammation of the cord, and it happens to be that when this occurs, it's often at one level, or one or a few levels, and we call that transverse. It happens to be transverse across the cord. So transverse myelitis is the name that we give to inflammation of the cord. And if we can do an LP and prove that this spinal cord disorder is inflammatory, then we think about the things that cause transverse myelitis. There is actually a list. Things like MS, neuromyelitis optica, sarcoid, there's a list. But if we can figure out its inflammation, it's a type of transverse myelitis. Good. What about infections? What's the classic infection that you should think about with spinal cord diseases? Syphilis, yeah. Syphilis or tertiary syphilis is a very common, or very classic spinal cord disorder, and it presents as tabes dorsalis, a dorsal column predominant process, right? There's degeneration, there's damage to the dorsal columns. Patients have a significant amount of proprioceptive or vibration loss, and you can see damage to inflammation, swelling, and degeneration in the dorsal columns on the spinal cord. Good. So infections, syphilis. What about neoplasms or perineoplastic things of the spinal cord? All right, there's tumors. Tumors of the cord, astrocytomas, ependymomas, those are probably the two most common things you'll see in the cord, though you can see a variety of different tumors, and there are some perineoplastic things. They're less common, but there are some things to think about. Anti-Hu antibody syndrome may be one to think about, but yeah, neoplasms, perineoplastic processes, those do affect the cord. What about toxic metabolic conditions? The classic one is probably a vitamin B12 deficiency. Anybody know what the other name of that is? What's the other name of vitamin B12 deficiency? Subacute combined degeneration. Yeah, it's degeneration. Degeneration is just dying of cells. That's from nutritional loss of the B12. And this often presents over the course of several months progressively. That's subacute. And what do we find on imaging or on gross pathologic sectioning? We find combined degeneration of the dorsal columns and the corticospinal tract. Yeah, so patients have this very profound proprioceptive loss from the dorsal column dysfunction, and they get a little bit myelopathic, increased reflexes from the corticospinal tract dysfunction. Vitamin B12 deficiency. Yeah, that's something to think about. Actually, interestingly, nitrous oxide poisoning can present just like vitamin B12 deficiency because it acts in that same pathway. Vitamin B12. Good. And then what about inherited things to the spinal cord? Yep, things like spina bifida, that'd probably be one to think about. There's also some degenerative things, spondylosis you could put in that category, but yes, there are some inherited things that could run in families and affect the spinal cord. So again, we're not going to go through each of the diseases, but we can use the types of diseases, the types of pathologic processes that affect the nervous system, inflammation, infection, neoplasm, toxic metabolic dysfunction, inherited disorders, and the others to guide our differential diagnosis formation and our testing. Turns out this works really well in the periphery and in the spinal cord. Again, in the brainstem and brain, it does kind of become more challenging, but the same logic is going to hold true, right? If you're looking for inflammation in the brain and brainstem, you're looking for on MRIs and LPs. That's what shows you inflammation. If you're looking for infection, you're looking for through the eyes of an LP. If you're looking for toxic and metabolic insults, you're testing those nutritional deficiencies or toxicities. You're looking for signs of other signs of systemic medication overdose or deficiency. Yeah, you're using the skills, the tools you have to look for the type of pathologic process, and that tends to narrow down your differential diagnosis. And so again, we're using our localization. to drive where we think this problem is coming from. Where we think this problem is coming from will drive our diagnostic testing. Testing of inflammation, testing of infection, of cancer, of toxic metabolic things, and of inherited things. Because once we know where and how the problem is manifesting, it becomes much easier to figure out what it is. So we'll conclude here, and I'll urge you guys to spend some time thinking about how you're going to build your own structure, your own method for thinking through these diseases. The patients that you encounter, the clinical experiences that you have will help refine your understanding of disease, but it's imperative to have a framework for reasoning through these clinical cases and giving yourself a recipe for how to think about and work through these cases in neurology. Thanks so much for your attention.